Good morning, I'm Dr. Karthik Raj. I would like to show up on the shoulder examination for academic point. Here is Mr. Kumar. Mr. Kumar, I would like to examine your shoulder for an academic.
Okay, thank you.
Thank you so much. So going ahead with the shoulder examination, I would like to do it with my patient in sitting posture in my office, so that would give me a clear clearance to my shoulder on a 360 aspect from the front, side and the back, and also help me to do a comfortable dynamic examination. Well, as well, I make the patient in supine posture, especially for examining the patient for shoulder instability, which the patient is mostly apprehensive and they can feel comfortable with the supine position. Starting with the general examination, I start with the examination of both the upper limb inspectatory findings. I look for the bilateral symmetry of the shoulder, any evidence of muscle wasting in and around the shoulder, about the arms, forearm muscle wasting, and I have a quick evidence of any thenar or hypothenar muscle wasting, and tell him to quickly move his fingers so to rule out any gross neurological lesion that could be missed. Going to the shoulder examination specifically, starting with inspection, I split it from the front, side and the back. From the front again, specifically we see for any wasting, symmetry of the shoulder altered, deltoid contour that's lost, bicipital weighting, and also looking for the normal prominence of the clavicle on either side, or any step deformity on the acromioclavicular or the sternoclavicular joint. From the side again, it's not much except for looking the deltoid prominence or wasting, or to look at the acromion and the acromioclavicular joint. More important to me will be from the posterior aspect, where I have a look. Can you turn? Yeah, thank you. To look for any evidence of wasting of supraspinatus or infraspinatus in their respective fossa, and compare it on either side. And also I look for the medial border of the scapula and see on either side if there is evidence of winging of scapula, be it the medial or lateral winging of scapula or any high riding scapula. At the same time, also look for the inferior aspect symmetry of the scapula, which could give me subtle evidence on scapular dyskinesia or scapular syndrome. So, not the least, I also look at the symmetry of the neck and the head posture of the patient posteriorly. Thank you. I then go ahead with the movements of the shoulder after the inspection before going to the special test, because it gives me a clear only. I start with the active movements. I make the patient to do functional elevation of the shoulder, which is going to be, thank you, clear rule out to any stiff shoulder or periarthritis where characterized by global shoulder movements, and even gross injuries of the rotator cuff where the patient may not be able to abduct the shoulder fully. And the second movement I see is asking the patient to do internal rotation on both the side and to compare the level of to which his thumb reaches, usually till the lower border of the scapula. Thank you so much. Yeah, good turns. And also I assess the external rotation movement. Yeah, it's compared on either side, it's equal. Yeah, it's going to be fine. And after doing this, I go for the passive range of shoulder movements, starting with functional elevation. Yeah, while checking for the functional elevation, I keep a hand on the scapula. One is to stabilize it and also to see if the glenoschapulothoracic rhythm is maintained, or any abnormal dyskinetic movements that I could observe in the scapula this way. And also I check for the rotation in abduction, 90 degrees, and also at 0 degrees of abduction. That's really important, passive and active. It could be an early sign of marker in periarthritis shoulders. And I compare the movements with the other side to check it bilaterally. Checking the external internal rotation 90 degrees is especially important in athletes to not to miss out the shift of glenoid rotation R, especially in glenoid internal rotation deficits, good kind of patients where we're going to have a look at the shoulder for throwing shoulder injuries. The other thing is going for the special test of the shoulder. I split it into the shoulder test for impingement, acromioclavicular joint, the rotator cuff, and shoulder instability. Starting with the shoulder impingement test, the two important tests being the knees test, wherein I take the patient's shoulder passively for abduction and 90-degree forward flexion, and check for any signs of impingement, be it patient discomfortability or pain, because this is the posture of impingement. And the other test being the Hawking-Kennedy test, which is similar, but the elbow in 90 degree, shoulder in 90 degree of abduction and forward flexion, and internal rotating the shoulder passively, and just check for any signs of discomfort or pain with the patient. And the other test that I go ahead for impingement will be to check for any point tenderness or the anterolateral aspect or the angle of the acromion that could help me either. Now going ahead with the rotator cuff test, we're starting with the test for supraspinatus. I start with the Jones MT-CAT test, which is again with 30 degree of forward flexion and 90 degree of shoulder abduction. The patient's thumb pointing down, one hand palpating the supraspinatus on the fossa. Can you please push it up? Yeah, checking for the power of the supraspinatus and also any pain there with the elbow in extension. So this test could clearly show if there's going to be a full thickness tear, the patient is not going to be able to do that, and partial tear or tendinitis, patient could have a weakness along with the pain while he's doing that. And the other test being the Jobs full CAT test, which is the exact same but not with internal rotation, just with the thumbs pointing up. Well, for the supraspinatus, the MT-CAT test is more significant because by internally rotating, we're going to negate the action of deltoid as an abductor, so we could easily pick out the lesions of the supraspinatus muscle. The next muscle that I'm going to test is the subscapularis. This is where I go. Can you please do the lift-off test? So the patient takes to internal rotation. Can you push my hand? Yeah, and to check for the strength of pushing my hand back. Clearly he has a good strength, which rules out any subscapular lesion. The other test being the Napoleon's belly press test, where I make the patient tell the patient to press his belly with both the hands, whereas getting his elbows out, yeah, and not pressing at the wrist, yeah. This could, thank you, be not possible in cases of subscapularis muscle injury. The other test for subscapularis could be a pair hack test. I take the patient to the other side and ask the patient to push his elbow down, down. I do this in 0 degree abduction and also in around 60-80 degrees of abduction, which segregates the muscle fiber injury, lower fiber and upper fiber injury depending on the degree of abduction. Okay, a good test for subscapularis. The other muscle that we need to really examine is going to be our external rotators. There's the infraspinatus and the trevis minor. I start with the external rotation stress test. I check the power of external rotation on each side. Yeah. Thank you. And the other test is taking into abduction and making the patient, checking for any lag in external rotation and making hold in this position, asking the patient if he's able to hold it. If he's not, his hand can fall forward, which is classically goes by the Hornblower's test. Again, checking for external rotation stress in abduction is going to check on the on the teres minor, but with 0 degrees of abduction is going to stress on the infraspinatus muscle. Then, having completed the rotator cuff, supraspinatus, subscapularis, infra, and the teres minor, we next have another important muscle to take on is the biceps, especially the long head of biceps. The point will be for groove tenderness, which we had seen earlier. The other two important tests being the Speeds and the Ergoson's test. Speeds test is just abducting the shoulder, elbow in extension, please. Yeah, elbow in extension, abducting and checking. Can you push it up like that? Yeah. Checking for the power and any pain the patient might feel in the biceptal groove. Thank you. And the other test being the Ergoson's test with elbow in 90 degree of flexion by the side of the chest and making the patient pronate. Now I need to do a resisted supination, yeah, please, yeah. And to see for any discomfort. Of course, the patient is completely fine here. So these are the two important tests for any bicipital lesion. The other joint that is important is the acromioclavicular joint. checking for the point tenderness is very sensitive. At the same time, I take for the cross-body Apley's cross-body abduction test. I take it to the tip of the elbow to cross the midline and to see for any discomfort or any popping up of the distal clavicle joint per se. The other quick test for kind of a slap lesion would be the O'Brien's test. It's again the similar way of Jobs, but with a little bit of internal rotation and with the forward flexion of the patient and also adduction. I check the strength of the patient to push it up, with internal rotation and then external rotation. If the patient's discomfort disappears on external rotating, it is more indicative of slap region. Of course, there is a number of array of tests for slap, but not really all the tests are confirmatory, or the good significance level for slap lesion is a little tricky on clinical examination. The last point will be to assess the shoulder for instability. Can you please lie down? Yeah, I make the patient usually to supine position, which I told. So this way, I keep myself very simple to see for any anterior instability. I go with the Jobs apprehension test, take the patient to 90 degrees of shoulder abduction, slowly external rotating, and to check for any patient discomfort. The patient is absolutely fine. In case of discomfort, and I'm going to do a Job relocation test where I give the pressure anteriorly and then going ahead to external rotate, in which case the patient will be reaffirmed and he's going to be having less of a discomfort, which is again clearly demonstrating the anterior apprehension. Similarly, it can be done for posterior apprehension in the other way around. And again, I do a kind of a shoulder latchman very quickly, stabilizing the scapula and the humerus, trying to slip the humerus out anteriorly and posteriorly to see if it is subluxating or even I'm able to dislocate. In this case, it's very clear, and it can be the degree of translation can be graded 1, 2, 3 dependingly to assess for instability in this way. The other test, can you please sit down? Other test would do the sulcus test, or to check for the inferior laxity of the shoulder. I push the arm by the side of the chest. I give a thrust, inferior thrust to the shoulder, and to see if I'm able to palpate any sulcus below the acromion. Is fine. Again, depending on the amount of sulcus, I grade it to 1, 2, 3 based on the centimeters of grabs, the gap that appears there. Yeah, you can come back. Then after this, I go to a quick neurological examination or sensory involvement, especially the Regiment sign of this year, which is highly specific for your axillary nerve involvement. Again, compare it bilaterally for feeling the sensations over here. And no evidence of muscle wasting, no neurological, and I have a fast look on the reflexes, if any of the, to complete my neurological examination, the bicipital reflex and the supinatal reflex, to complete my neurological examination of the upper limb. So I think this gives there are other number of tests for the specific tests for the shoulder, but this is an overall view of shoulder examination. Thank you.